There is actual good data in the medical literature to show that PCBs cause gut barrier inflammation. So we don't think about that when we eat, salmon that's supposedly good for us that came from a farmed operation that's high in PCBs. But glyphosate, which is also in our conventionally grown grains, mostly, and GMO foods, soy and corn and canola, can do the same thing. So I think not only do we have to keto-adapt and probably bring in probiotics, but we have got to give people the opportunity to eat a clean diet. And in my mind, that means food that's organically grown. I think we've kind of come to the point where we can no longer say, well, the Environmental Working Group has the clean 15 and the dirty dozen, and just try and eat from those two groups. I think we're past that. For the first time in recent history, the USDA has admitted that we now have higher and higher levels of DDT in our food supply. Why? Because we're getting more and more food imported. We eat a global diet, and DDT is used around the world.
Hello and welcome back. This episode is proudly sponsored by Health IQ, a progressive and forward-thinking life insurance company that rewards health-oriented people, nutritionally oriented people, physically active people just like you and me save money on their life insurance premiums. See if you qualify and get a free quote by going to healthiq.com/HIH. That's healthiq.com/HIH. Let's dive into the show with Dr. Lyn Patrick.
Hello friends, it's Mike Mutzel here with High Intensity Health. Thanks for tuning back into another episode. I'm very excited to be with Dr. Lyn Patrick, environmental medicine expert, and you do a lot of research too when it comes to liver function. So today we're going to talk about keto-adaptation and non-alcoholic steatohepatitis, also known as fatty liver. So Dr. Patrick, thanks for being here. I've been a fan of your work for a very long time.
You're welcome. So probably I need to shortly introduce how I got into this.
Let's do it.
So I was an AIDS doc. About half my practice was HIV and AIDS. In the 90s, when the non-nucleotide reverse transcriptase inhibitors, which is a long word for the anti-HIV drugs that actually worked, came on board, we noticed that our patients started getting strange liver abnormalities. And in fact, that was the result of the drug. That was the effect of the drugs. They did work. They kept people alive, but our folks got lipodystrophy, which means they got fatty liver. So they also had co-infections with hepatitis C, and that was another added burden on top of the medication. So when we started doing some research in hepatitis C, we saw that those folks, whether they had HIV or not, were really at risk for fatty liver. And now we know it's about half of the hep C population. So time goes on, and I think the new figures from 2015 are that 25% of all Americans, regardless of whether they have any other infections, have fatty liver disease. So 1 in 4. And in kids right now, we're looking at 10 to 13% of all children have evidence of fatty liver. So it's an epidemic. So we've worked really hard to look at how much of this is diet, how much of it is American lifestyle, diet and lifestyle induced, how much of it is toxicant induced, how much of it is high fructose corn syrup, which we know now is a huge problem with fatty liver. Robert Lustig talks about that. I think he's a pediatric endocrinologist, has written books about high fructose corn syrup. So there's so much to say about this that instead of just doing the broad brushstroke, we're going to kind of narrow down into what really looks promising.
Would love to do that. And small intestinal bacterial overgrowth, you were talking about, like gut disorders, there's a high correlation with fatty liver with that too.
So what we know is that just fructose, when you just eat fructose, so of course most of the fructose we get, the volume comes from high fructose corn syrup. But people who are also getting a lot of fructose from fruit, high fruit diets, are also having the same effect. That when you get up around 50 grams a day, which is not unusual for people between the ages of 13 and 30, they get an average of 60 to 70 grams a day of fructose. You start getting endotoxemia from dysbiosis in the gut. So, there's an old naturopathic adage that all disease starts in the gut. It's never more true than it is with fatty liver syndrome, because that dysbiosis causes endotoxemia that primarily affects the liver and causes systemic inflammation. So the liver becomes inflamed, and those cytokines, those messengers, spread out to the rest of the body. But the liver definitely takes a hit.
There is this notion of the second hit hypothesis. So you mentioned this metabolic endotoxemia. So we're having the sugar and fructose and so forth. We're absorbing bacterial fragments. They hit the liver. Then what happens?
For those of you that don't know about it, in gastroenterology and hepatology and fatty liver, there's called the two-hit hypothesis. So the first hit is fat in the liver. So the liver starts importing and storing triglycerides. Where does that come from? In most people, it's sugar and fructose and glucose and high carbs. So that's primarily the source. And you can live with that for a long time. So many people who have fatty liver now may die of something else. You know, they may die of cardiovascular disease or old age. But then the second hit comes along. And the second hit is what causes the scarring in the liver that leads to cirrhosis. And unfortunately, the other thing we're seeing is primary liver cancer. Hepatocellular carcinoma is the medical term. So where is this second hit coming from? Well, it's coming from a free radical cascade. So all these free radicals that the liver's being exposed to, and a lack of antioxidants to balance that out. Mm-hmm. Now those free radicals can come from a variety of places. We know there are toxicants. There are about 6 or 8 toxicants that we know are directly related to fatty liver, like PCBs, polychlorinated biphenyls. The primary place we get that is from farmed salmon. And those toxicants, they accumulate in the body, and they take a long time for us to get rid of. 20-year half-life. So yeah, 20 times 5 is 100. That's how long it takes. Yeah. You know, most of us will be dead. BPA, bisphenol A, where do we get that? We get it from thermal receipts. There's pretty good evidence it can be absorbed through the skin. We get BPA from our polycarbonate water bottles, you know, if we drink out of polycarbonate water bottles. We get BPA because it's a water pollutant, so it is actually in our water supply. Good reason to have a point-of-use water filter, you know, so that you're not drinking BPA. So these toxicants are ubiquitous. You know, we're all exposed to them. It's not an occupational exposure. It's you go to the grocery store, you get a thermal receipt. You know, you put Purell on your hands. Yep. Use that Purell. It has dermal absorption enhancing chemicals in it, because all personal care products, we want to absorb them, right? Make our hands nice and soft. That allows the BPA to be absorbed into the bloodstream. And the main BPA researcher just did an elegant study on this, where he actually had his graduate students get Purell, like they had been to fast food places and observed that this happens. They got Purell on their hands, and they held a receipt for about 4 minutes was the time that it took for the BPA to be absorbed into their skin. And they measured blood levels, and then elegant part of the study is they took those Purell-coated hands with the thermal receipt contact BPA, and they took French fries and ate them. And they found out that more BPA came in through the skin than went into the gut. Wow. So, you know, it sounds conspiracy theory-minded, but it's not. There's good evidence that we actually absorb some of these. So what we know about these toxicants is not only do they cause high levels of reactive oxygen species free radicals in our bodies, but they also affect our endocrine system. So the endocrine organ that we know and love, our newest endocrine organ, is adipose tissue, right? Our fat is metabolically active. And we know that these toxicants, particularly BPA, which is ubiquitous, can suppress the levels of a hormone called adiponectin, which you probably know a lot about adiponectin, right? We know that adiponectin is so important in normal liver function. It's so important in normal insulin sensitivity. It's very deficient in diabetics. You know, literally adiponectin is tanked in diabetics, but also in fatty liver disease. Why is adiponectin tanked? BPA has the capacity to prevent the adipose cells from actually making adiponectin. So No adiponectin, lots of leptin, leptin resistance, obesity, insulin resistance. It's the perfect storm. So this is only one, I'm giving you my favorite example, but it's only one example of how fatty liver happens in people who least suspect it. More common in diabetics, more common in folks who are obese. But there are a lot of skinny people who have fatty liver syndrome.
And kind of if we want to look at the root cause of some of this metabolic derangement, if you will, so that's like a prime example of kind of an environmental toxin-induced metabolic derangement. But we were talking offline, what's a chicken or the egg? And it sounds like this dysfunctional fat cell. And one characteristic of that, as you just alluded to, is the low adiponectin. That's one of the adipose cytokines that we want high.
Yes.
Most of the other ones, like resistant is fat and leptin, we
right.
want low.
We want to suppress all the rest of them, but adiponectin, you've got to have adiponectin in order to have insulin sensitivity. And the one thing we know for sure is that this whole sad story starts in the adipose tissue. For years and years we thought, well, there's something wrong with the liver, right? Because the liver is storing all these triglycerides. But the liver receives signals from the adipose tissue telling it, stop making glucose, because the liver, makes glucose, glycogen breakdown, right? Stop making glucose and stop storing triglycerides. So the signaling is all screwed up.
And it's from the fat cell. The message is the fat cell is calling the liver to say, hey.
Yes, it comes from the fat cell. So this is mostly brown fat, what we call visceral fat, the fat that's around our organs, right underneath our skin, the metabolically active fat.
So before the dog interruption, we were talking about kind of the hierarchy of communication and this sad story of this ubiquitous insulin resistance, metabolic derangement. People, we were talking about, we tend to think, it's a liver's problem, but it's really this sick, enlarged adipocyte that's sending communication.
Right, and I would be really remiss if I didn't mention the endocrine system. So the perfect storm, the other part of the perfect storm is that we know that men who have low testosterone are much more at risk for fatty liver syndrome. Interestingly, there's actually been some intervention studies that have shown when testosterone levels are replaced, fatty liver regresses. Wow. So testosterone, master signaler in both men and women, it helps the brain function and normalizes cardio function, cardiovascular function. But it appears from this phenomenon that we see over and over again that the endocrine system, in specific, we're talking about testosterone, but we can't leave out thyroid because people who are hypothyroid, are at equal risk as well. That when the endocrine system is lacking in adequate hormonal production, and we know that xenoestrogens will do this, right? Xenoestrogens will suppress testosterone as well as alter estrogen, that they can also play a big role in fatty liver. So hypogonadism and hypothyroidism are the two big kind of intervening variables there.
Yeah, really, really good point. And so what about the crosstalk with muscle in the liver? We're talking about that too, kind of like so, the purpose, I guess, of kind of figuring out which one comes first gives people, clinicians and just laymen, like, okay, I should work on a different dietary strategy or exercise regime to help restore health to this tissue.
Exactly. So there are some really great interventions, particularly resistance exercise, that have been shown to improve insulin signaling, right? Insulin signaling, any improvement in insulin signaling is helpful for fatty liver. So if the muscles become more insulin sensitive, that will help minimize that triglyceride storage in the liver. It won't completely override the problem with adipocyte signaling, but it certainly helps. And so right now, as we spoke about before we got started here, there are no FDA-approved drugs for fatty liver disease. This is a $6 to $8 billion industry. So big pharma has got all these drugs in the pipeline, which may or may not be helpful. They're very targeted drugs, signaling agents that will help upregulate and downregulate some of the signaling mechanisms that are awry. I think the problem is, which I'm sure, your smile is telling me you already know what I'm going to say, is that we really cannot overlook the role of high fructose corn syrup, trans fats, and unfortunately, and we'll talk more about this, a high saturated fat diet. of the types of saturated fat that are common in the American diet, their role in creating this problem in the first place.
Very, very interesting. And some of those signaling pathways, are they synergistic and congruent with like mitochondrial upregulation, like AMPK and PGC1 alpha? Are those
yes,
some of the pathways?
AMPK, absolutely. So one of the other things that we know is that there's more mitochondria in the liver than any place else. Fascinating, right? I thought it was the muscle, but no, it's the liver. The liver is so rich in mitochondria because it has so many labor-intensive jobs to do. And nowhere else is mitochondrial toxicity and mitochondrial function more obvious in a disease state. Well, maybe cognitive function might be a close second, where we see that mitochondrial toxicity is a huge problem. So we know for mitochondria to make energy, to make ATP, they also have to make a lot of reactive oxygen species, right? We produce a lot of free radicals. Now, usually in the liver, superoxide dismutase and catalase and glutathione peroxidase, very high levels of those enzymes. They're called, the master antioxidants. They're at the top of the hierarchy. Vitamin C, vitamin E, vitamin A, they're down here. These enzymes, without them, we couldn't do anything. Fascinating, but in fatty liver disease, those enzymes are tanked. No SOD, no catalase, no glutathione peroxidase, because the body cannot handle the amount of reactive oxygen species the liver has to deal with. Trans fats are a big problem there, but all the things that we consider environmental pollutants, the big way that environmental pollutants wreak havoc in our bodies, and I'm including cancer here, is they are responsible for the generation of huge amounts of these reactive oxygen species. So that leads to mitochondrial toxicity and basically very low functioning mitochondria. And that is, that's the huge, and not only the energy generation mechanism, but that allows for repair. When you get damage in liver cells, it's your mitochondrial function that allows you to repair them. So I'm not sure I'm answering your question, but upregulating the AMP kinase, that's really crucial because that's downregulated in fatty liver disease. So anything you can do, bottom line, to increase insulin sensitivity and decrease insulin resistance will help minimize the first hit, the increased levels of fat, and actually the second hit, which is the damage to those liver cells that isn't repaired, eventually leading to scarring and cirrhosis.
Sure. And natural ways to kind of upregulate some of those, like superoxide dismutase and catalase, those reparative antioxidant free radical type enzymes, right? So a phytonutrient-rich diet, perhaps.
Phytonutrients, exactly, polyphenols. So in other countries, they're actually doing research looking at polyphenol combinations in treating fatty liver disease. And just the ones you would expect, the berry-rich polyphenols, are the ones that actually can repair damage, minimize the damage in the first place. So in some of the European countries, they're actually using those as interventions. We're not doing that here. We're doing bariatric surgery and other interesting interventions and looking for, very highly expensive drugs as an intervention. Now, to their credit, most physicians know that the interventions of diet and exercise are the only accepted interventions for fatty liver disease that are reparative. And there's been very good data on weight loss. You can actually reverse not just fatty liver, but the progressed form called NASH, you mentioned it, steatotic hepatitis earlier on, that leads to cirrhosis and liver cancer. So just with weight loss, we've seen reversals of cirrhosis, just with weight loss. It's significant amounts, but we have seen it. How is that possible?
Yeah.
That's your next question.
I was going to say that. I was going to say, actually, I was going to say that's a nice segue into the liver's function in burning fat. And a lot of people that tune into these podcasts and stuff are interested in ketosis, and kind of the ketogenesis occurs within the liver. So the question, and then we can talk more about where you were going, is if we have NASH or fatty liver, or because it's probably a spectrum, are we able to make ketones, or are the cells kind of damaged?
Okay. Not at all. So there was a meta-analysis, hold on to your seat,
Sure. Yeah.
475 studies on using probiotics for fatty liver disease, right? So there has been just that amount of data looking at reversing endotoxemia. So it's a two-pronged approach. We can't just do ketogenesis by itself. So keep that in mind, that we're not just going to do it by itself. But let's just talk about keto-adaptation. So the literal minute that you decrease insulin stimulation by the hepatocytes, that you actually lower insulin levels in the liver, you reverse the process. So there are some really good studies in human beings with fatty liver disease, putting them on a ketogenic diet. Right.
The moment that we drop the insulin need,
insulin levels in the liver, right, that reverses the process. So it is the elevated insulin levels in the liver that drive that process of triglyceride storage, but also gluconeogenesis, raising glucose levels, which then further raise insulin levels. So this has been actually very effective, especially in obese patients who then, of course, start to lose weight when they go on, I'm going to say, a keto-adaptive program rather than just a ketogenic diet. Now, here's the trick, is that keto-adaptation, as you know, is different than ketogenic diet. Ketogenic diet is just eating, 70% fat, 15% protein, less than 20 grams of carbs. However you want to spin it. There's no evidence that that's a long-term safe protocol in fatty liver disease. But we know it's a very good initial intervention to turn things around, because we can see, we have actual evidence from liver biopsies. They've actually done a couple studies where they've looked at liver biopsies in patients who they put on ketogenic diets. And this was actually started because it was originally used research-based for morbid obesity. So I hate that word, but it's BMI over 40. And we know that in folks who have a BMI over 40, it's literally guaranteed that they not only have fatty liver disease, but that it's progressed to the dangerous form of NASH. So these interventions were originally used in people who had BMIs over 40 to help them really normalize their insulin resistance and begin to lose weight, begin to return to a normal metabolism. So it's very helpful. It's a very helpful intervention. Now, the long-term studies, the only ones we really have are on mice. And in mice, when we look at a long-term study, it's not helpful to have them on a high saturated fat or combo monosaturated, polyunsaturated, saturated fat diet for a long period of time.
Why is that?
Because it appears to, there's so much going on in fatty liver disease that we don't know, but there's some way in which that influx of fat into the liver can't handle it.
Long term.
So long term.
Interesting.
So what's the definition of short term? What's the definition of long term? So the definition of short term really is months, like 3 months. But I think that when we really get a handle on this, what we're going to see is that what you're doing with this person is not only taking them off of carbohydrates, not just taking them off of sugar, but taking them off of an addictive alcohol we call high fructose corn syrup, right? And actually allowing them to detoxify from what I think, and trans fatty acids too, but this high fructose corn syrup research, it's really clear that high fructose corn syrup causes hypertriglyceridemia in the liver and a million other things. But it needs to be taken out of commerce. And I know you know the story that we found mercury in high fructose corn syrup. We published that paper in 2009, I think. And we hoped that that would be the fuel that would help move high fructose corn syrup out of commerce. Unfortunately, it was not. But there is in the United States, it's illegal in Europe, but in the United States, there are 3 manufacturing plants that use mercury in the process of manufacturing high fructose corn syrup, and there is contamination of the finished product. We've proven that.
Wow.
Through our studies.
This is actually news to me. Yeah, I didn't know. Huh.
I'll give you the paper.
That's brilliant. That's really good to know.
Significant amounts. And we're talking about the population in the United States where young people who are mostly drinking it between the ages of 13 and 29 are drinking enough of this stuff that we know that it's causing insulin resistance in them. It's absolutely causative of insulin resistance. So I think the beauty of keto-adaptation or ketogenic diet is that not only does it improve insulin sensitivity, but it's taking away from your body a toxin that your liver can't handle.
Right, and also maybe you're having less toxic foods potentially. So if you're having avocado and coconut and more greens and things like that. So there's multiple mechanisms.
Platefuls of vegetables. If you want to do a true paleo diet, you're going to be eating more leafy greens than you can imagine.
Yeah. Right. And then so at what point would someone introduce carbohydrates back in once they see their liver enzymes drop?
So that's. I am not an expert in keto adaptation. I refer to my friends like Dr. Bonnie Nedrow, who's been doing this with large groups of people for 5 years. So she has actual data on this. But when you're checking your blood ketones, you're checking your blood beta hydroxybutyrate levels, and then after a couple of months being able to add in some carbohydrate and then seeing if you can go back into ketosis weekly. And see, that's the tricky part, and it's harder for people with fatty liver disease. So it's important to help them figure out how to do that. Antioxidants are crucial. In pediatric NASH, kids who have fatty liver that's progressed, they've shown that just simple old, drugstore vitamin E can reverse liver damage in these kids. Wow. Simple, I think maybe 1,000 international units, something like that, 800 to 1,000. D-alpha tocopherol, which of course we would recommend the whole complex because it's like the B vitamin family. We need all of that. Tocotrienols and tocopherols. But there's definitely a serious antioxidant deficit in these folks, so that has to be addressed. High levels of 8-hydroxydeoxyguanosine in these folks, as well as other markers of oxidant damage. So then we also have to bring in, we can't forget about the probiotics, right? Because again, 475 studies on probiotics that show clearly that giving people probiotics, and we're talking basically about bacillus, lactobacillus, bifidobacterium, improves liver function in these folks. How I started getting turned on to this is I read an article. It was one patient case from Germany where they had a gentleman who was in a coma because he was going into liver failure. And they gave him a form of E. coli that's used in Europe, E. coli Nissl, that we can't get, unfortunately, here in the United States.
I think you can get it.
You can get it in Canada. And they gave it to him through a feeding tube. And they watched his ammonia levels come down over a matter of hours. I think it took like maybe 3 days. They actually brought him out of a coma. And I thought, this is unbelievable. This is published in the medical literature. The Germans know about this. To give probiotics. This was right, I think probably in the 90s, mid-90s, before the studies really started. But that led to just this flurry of studies looking at probiotics. And the majority of them, VSL3, most commonly used one, but the majority of them are really just combinations of 1 or 2 lactobacillus strains and a bifidobacterium strain. Yeah. And what you're doing is just, putting some competition in there. But what I always think about, very important, I think, for us to look at why do we all have such problems with endotoxemia? We see it in brain problems, right? We see it in cognitive decline. And I think we have to look at why our guts are so inflamed. And what's behind that? Is it our diet? Is there something in the diet that can cause this? And there is actual good data in the medical literature to show that PCBs cause gut barrier inflammation. So we don't think about them hardly ever. We don't think about that when we eat, salmon that's supposedly good for us that came from a farmed operation and that's high in PCBs. But glyphosate, which is also in our conventionally grown grains, mostly, and GMO foods, soy and corn, and canola, that glyphosate can do the same thing. So I think not only do we have to keto adapt and probably bring in probiotics, but we have got to give people the opportunity to eat a clean diet. And in my mind, that means food that's organically grown. I think we've kind of come to the point where we can no longer say, well, the Environmental Working Group has the clean 15 and the dirty dozen, and just try and eat from those 2 groups. I think we're past that. For the first time in recent history, the USDA has admitted that we now have higher and higher levels of DDT in our food supply. The market basket survey they do every year showed that. Why? Because we're getting more and more food imported. We eat a global diet, and DDT is used around the world. And DDT has its own havoc that it wreaks on the gut because it's a pesticide. But I think we really have to look at, especially in patients with fatty liver disease, giving them the opportunity to have a diet free of these gut-inflaming chemicals.
Because the endotoxemia linked with that, because
Yes.
that weakens the barrier, which allows these bacterial endotoxin particles to come in, and the first contact point, right, is the liver, so they're going to cause damage.
Right, but also fructose causes endotoxemia, and that's what it's so. I talk to doctors, they're like, fructose, it's from fruit, it's natural.
It's healthy, it's low glycemic.
Right, but what we don't realize is that fructose causes fermentation in the gut, and a little bit we can handle. I have no problem with people eating a piece of fruit every once in a while.
Sure.
But the 70 grams that young people are getting in the multiple sodas that they drink every day, or the sweetened iced tea now. If you go into a convenience store, you'll see that there's high fructose corn syrup in every beverage there, bar none. That amount causes endotoxemia. This has been proven in multiple preclinical animal studies. Mm-hmm. So I think that is one way that we are actually causing fatty liver disease in our population, literally causing it.
Let's talk about alcohol. I think that is it can be a stress, obviously,
Absolutely.
to the gut, and there's issues with metabolic endotoxemia associated with alcohol consumption.
Correct.
So
yes. So this is called non-alcoholic fatty liver disease. Mm-hmm. Fascinating. The definition is less than 21 drinks a week in men and less than 14 drinks a week in women. Now, that's the cultural norm. But in my book, that is enough alcohol to contribute to endotoxemia, because we know clearly alcohol does contribute to dysbiosis and endotoxemia. That's in the hepatology literature. So the recommendation for patients who have fatty liver disease is to minimize their intake of alcohol. I have a different viewpoint about that. Maybe because I worked in drug and alcohol treatment, I don't know. But I think that no alcohol is the appropriate recommendation for somebody with fatty liver disease, because we have clear evidence that lower amounts contribute to fatty liver. So there's an odd paradox in medicine where we know that this much will be damaging for you, but we're just going to recommend that you minimize it, and we're not going to tell you to just avoid it. Unfortunately, we cannot get around the fact that alcohol is a metabolic toxin. Mm-hmm. And maybe for those of us who are extremely healthy, we can handle it. But people with fatty liver disease, and especially people with NASH, they're not healthy and they can't handle it. So when you look in the literature, it's fascinating because the hepatologists came out, they believe they have coined the term endotoxemia. In a paper in 2009, they said, yes, we have animal models of what we call endotoxemia. And I learned about it in naturopathic medical school back in the 70s, the late 70s. And so I've known about it. They didn't coin that term.
Right.
But what they have figured out from really good preclinical studies is that saturated fat, but remember what's in that saturated fat, alcohol and fructose together create the perfect storm of endotoxemia in the gut. But they're not talking about avocados or coconut oil or macadamia nuts. They're talking about soy oil, genetically modified soy oil, which is high in glyphosate, canola oil, and meat. Beef, because of the way that cattle are farmed and grown, they can carry an accumulation of toxicants. Mm-hmm. And so we have to kind of redefine paleo for people with fatty liver disease. It can't just be eat as much meat as you want. Mm-hmm. We have to be judicious, and we actually have to mimic what our Paleolithic ancestors ate, which was mostly plants, lots of leafy greens, and a little bit of, as clean a meat as we can get, pasture-raised meat. So I actually went into the studies. I looked at the trade names of the high-fat diet feed they gave the mice, and it's literally tallow, soy oil, and lard. And that's what they feed these mice. So this is where that whole hype of high-fat diets are bad for people with fatty liver. No, tallow, lard, and genetically modified soy oil high in glyphosate are bad for fatty liver. And it's, as my friend Artis Simopoulos, who's this wonderful doc who has studied the Greece, the real Mediterranean diet from Crete says, the term high-fat diet's unscientific. It's an unscientific term. We should stop using it.
That's a brilliant point, because you're not differentiating or qualifying those fatty acids. And I mean, if you look at like olive oil or olive fat, you have hydroxytyrosol and other polyphenols, which will neutralize this endotoxin that we're talking about. So
exactly.
So important. Yeah. So when people see the headlines in Science Daily or New York Times that say high-fat diet causes X, Y, and Z, again, it's so important to read the materials and methods of the actual study. And unfortunately, that's not in the abstract. So to the average consumer, they just see high-fat diet is bad. Yeah.
But I think we just can't use that term anymore.
Yeah,
we can't accept that term means anything. It doesn't mean anything. And I think we have to deconstruct that. You and I have to deconstruct that literature, that data, and say, let's do some studies. Let's look at some studies where mice are fed clean fats and see what happens. Now, I'm still willing to say, given all of that a high-fat diet is okay initially, and probably for the first 3 months at least, and maybe 6 months in people with fatty liver disease. However, because everybody's individual, any physician, any clinician who or any healthcare provider who puts their fatty liver disease patient on that type of adaptive program must make sure that they're checking their blood work. They've got to get their liver enzymes checked. I would say every 3 to 4 weeks, that not only ALT and AST, but GGT as well. You've got to look at kidney function as well, and other markers, other fats, blood fats, plasma lipids as well.
Like red blood cell, PA-DHA and things?
Well, that would be ideal, absolutely. And we know that red blood cell fatty acid markers are altered, in patients with fatty liver disease, as they are altered in most people with chronic metabolic syndrome related problems, cardiometabolic syndrome. And that's the real, I think there's some evidence that giving eicosapentaenoic acid and docahexaenoic acid, DHA and EPA, are reparative in fatty liver disease, especially if there's hypertriglyceridemia. But I think I would hate for that to be used like a drug without all these other interventions, because it has to be done as a package deal. And people have to start exercising, as you know, resistance exercising, as they are able. They've got to start doing that. They've got to get their muscles kicked in.
Love it. So you mentioned EPA-DHA from fish wool. There's some good research that increases adiponectin. So that's in the adipocytokine we talked about earlier that kind of is linked with NASH and so forth.
Yes, and I would absolutely support, there's a good metabolic test now that looks at leptin and adiponectin, and I would support providers to use that test and use things like teach BPA avoidance. Learn how to do that, right? And test for BPA levels, because you'll see sky-high BPA levels in some of your patients. Personal care products. Women who use personal care products are loaded with BPA, and women don't know it. We have to actually start teaching our patients how to avoid these toxins that are ubiquitous in their daily lives, and then see, does that raise their adiponectin level? But absolutely, using essential fats will help that. Thank you for adding that in.
Yeah, I thought it was good. Maybe, I read some other research on higher dose melatonin and berberine. Maybe we could talk about different supplements. So I think we kind of hit on the lifestyle and diet changes. To put the icing on the cake for the supplements. What comes to mind? There's
good animal data on melatonin. I think that melatonin is the unrecognized immune modulator par excellence, because I use it quite a bit. I'm not afraid to use melatonin, even in high doses of 3 milligrams consistently. Russ Reeder, who you probably are familiar with, he's like one of the main melatonin researchers in the world. He's the editor of the Journal of Pineal Research. You won't see a melatonin article published in the literature without his name. It'll be last, Reader R. So he was at a conference, and I really wanted to talk to him. He was talking about looking at using melatonin in infants. There's a specific inherited problem with not being able to manufacture melatonin in infants. They've actually given newborn infants melatonin. Fascinating. They grow out of that. They learn how to manufacture melatonin. They take them off of the supplemental melatonin, and they continue to manufacture melatonin. I mean, they are able to then manufacture normal levels of melatonin. So I asked him, are you ever concerned about using melatonin long term in people? Is that going to suppress pineal production of melatonin? He said, absolutely not. I've never seen a case or a study in which melatonin production was suppressed by giving supplemental melatonin. And so melatonin is extremely useful in a variety of situations, including improving the ability of DMSA to chelate lead out of the body. Yeah, very important in using with chelating agents. There's no information with EDTA, but it wouldn't surprise me if it's helpful in that area, but definitely with DMSA. So melatonin, 3 milligrams at bedtime, is very helpful. Polyphenols, as polyphenol-rich a diet as you can give your patients, your clients, without increasing their glucose and carbohydrate intake. So that's a little dicey, right? Especially when you're looking at the fruit-derived polyphenols. But some of the elderberry, black raspberry extracts, you can get a significant amount of polyphenols with 1 gram or 2 grams maximum of glucose.
Mm-hmm. So the ratio of polyphenols to sugar is very favorable,
yes,
as opposed to maybe
favorable.
like an apple, where it might have quercetin, something in the skin, but there's a lot of glucose hit for the small amount of polyphenol.
Right, exactly, and you're not getting a lot of quercetin out of apples.
Yeah.
So I think it's better to really look at I'm going to say pharmacologic levels, because they really are. And good studies with those polyphenols, not only do they negate the dysbiosis that high-fat diets cause. And again, we're going back to, what are those high-fat diets? Mm-hmm. Well, they're not good fats. They're not healthy fats. But in addition to those bad fats, when you throw in polyphenols, you can actually negate the dysbiosis and the endotoxemia that occurs. That's probably because polyphenols support the production of good mucin layers in the gut and support the production of good bacteria in those mucus layers. I'm not sure because I can't remember the research. But it's clear that the polyphenols will prevent the endotoxemia. So polyphenols are very important. Vitamin E, just a good vitamin E complex of 1,000 international units of the whole thing, and that's usually just 1 capsule, is very important. They've actually done genetic studies with liver biopsies, pre and post. And the vitamin E is actually working at the gene level to prevent fibrogenesis in the liver cells. So it's a very inexpensive, extremely cost-effective intervention with very good data behind it, especially in children.
Wow. And that's even not the preferred, that's D-alpha tocopherol.
Crappy old D-alpha tocopherol.
Very inexpensive.
Again, I believe there's good research that shows gamma tocopherol would be more effective, but that's not what's been used in the studies.
Interesting.
Yeah.
So what would you recommend to someone? The DL form?
No, I would.
You go gamma.
The complex. I think there's enough good evidence that the effect you're going to get with a D-alpha, you're going to get that with a complex as well, and because it's an antioxidant response, and there's enough of the D-alpha in a complex to accomplish that end. In terms of getting the equivalent of 400 IUs of a D-alpha tocopherol.
So I want to just underscore a few things because I think, sometimes when we're an expert in something, we forget the significance. And we were talking about the high doses, or 3 milligrams of melatonin, that there's really no suppressed production from the gland. Very important for people to understand because I think anytime we give a hormone, endogenous production generally declines, right? And I'm glad that you alluded to that because I know many integrative functional medicine, naturopathic doctors who are scared of melatonin for that reason.
Yeah.
So thanks for sharing that. Point number 2 about the polyphenols with high fat, if you will, and how they can mitigate some of the endotoxin absorption.
Right, because that's one of the main, I know I've been in conversations where doctors have said that ketogenic diet stuff, it causes all kinds of metabolic problems, and here are all the studies that show that high-fat diets cause endotoxemia and dysbiosis and all that stuff. And I really have to ask them, have you looked at what that source of fat is? And is it the fat or is it the contaminant in the fat?
Oh my gosh, great point.
Yeah.
Yeah, and there's a difference between having garlic and ginger or curcumin mixed in with grass-fed beef, or just a bunch of grass-fed
Correct.
beef and butter, right? So we're talking about, like, food comes back to the delivery system a little bit. And so there was a study that just came out. I'll send you the article, the abstract I got. Emulsified fat tends to increase metabolic endotoxemia compared to the same quantity of fat that's not emulsified. So here we have people throwing in a lot of coconut oil in their smoothies and all that, right?
Homogenized milk.
Yes. So it's not only, it's the delivery system, the phytonutrients that may or may not be there with the fat. So we need to look at, like, it's three-dimensional.
Right.
A lot of layers.
Somebody like D'Agostino or somebody needs to do some basic research looking at, and there is a good model being developed for fatty liver, because the mouse model is not so great. But there is a good model being developed. And I think, I'll take the mouse model because we've learned so much from it. What is the difference between bad fat and good fat? Have you ever seen a mouse study where it's like, well, we gave them some fresh coconut, and then a little bit of fresh avocado, and then some really high phenol olive oil? Nobody's ever done that research. I've never seen it. No. So in a fatty liver mouse specifically.
Sure.
Yeah. So that needs to be done. Otherwise, we're just going to be unscientific.
Right.
When we talk about high-fat diets.
Which is really too bad. Lyn, this has been amazing. Thank you so much for just coming on. I want to have a moment of gratitude. Your work's been really fantastic. I think from just the toxicology world and Hep C and liver, now with Keto-Adaptation, I think it's key. You're co-administering this conference coming up in
Environmental
April.
Health Symposium 2018, we're going to be talking about lowering body burden, what works and what doesn't, and how that acts as a main driver for the resolution of chronic disease.
Okay, I'll put that link in the show notes. And then you have a clinical practice as well.
I don't actually, but I do have an online platform for continuing education, and I'm going to be teaching a whole course on fatty liver disease. I want to have, at least 100 integrative hepatology experts in practice before I, leave the planet. So I want to do that now. Is
that the next wave of health decline, is liver? Because there's not enough livers to go around in terms of transplant.
Yes, not only will it bankrupt the healthcare system, but there's no way that we can answer the need for liver transplants with the number of progressed patients. We're talking about 3 million Americans that have NASH right now, diagnosed or not, that are going to need acute care. And we can provide some of that. NASH patients don't have to progress to cirrhosis and liver cancer. They can regress, and there's a huge need for this in the functional medicine community. And very few folks coming forth to say, yes, we can do this.
Wow.
We don't need that $6 to $8 billion drug market.
So we'll put a link in the show notes for your online course and stuff like that, where people, I think it's a much needed, a mutual friend of ours, Ben Lynch, has really latched on to this fatty liver and
yay!
He's pretty into it. So.
Great. Oh, that's great. I'll have to talk to him about that.
He'd be a good one. Yeah, because you talked about all the mitochondrial density within the liver, but methylation reactions are occurring.
Yes. Oh, I have to say this, and Ben knows this. If you take methionine out of the diet of any animal, they will develop fatty liver. If you take methionine and choline, they develop it twice as fast. And as you know, methionine is the precursor to SAMe, and if you're draining all of the SAMe out of your body because you need it for glutathione or you have a bunch of SNPs, you can create a methionine deficiency.
Wow, which can be a problem. Great. Well, thanks. Keep doing the great work. Thanks for coming on the program. Really appreciate connecting with you here in Durango. So
happy to be here.
This is great.
With you.
Thank you. Cheers, Lyn.